Good afternoon and welcome to Webinar Wednesday. Today's webinar is on androgens, the good, the bad, and the ugly. My name is Tim Burke and I'm a member of the Dutch marketing team. I wanted to thank you all for taking the time to be with us today. I have a few housekeeping items before I introduce Mark Newman, who is our speaker today. We have a great opportunity for all new providers to try out a Dutch test for 50% off up to 5 test kits. This includes free clinical consults, video tutorials, and patient referrals. It's simple to sign up. Just click on the link that we will post in the chat and complete the Become a Provider form on our website. After you complete the form, someone from our team will set up a one-on-one appointment with you to answer all your questions and walk you through our onboarding process. For more information about Dutch testing and our webinars, email us at sales@dutchtest.com or call 503-687-2050. That will be also posted in the chat. I've added the slides, or will add the slides to the handout section at some point in the webinar today for you to access, and we will also be sending the slides out tomorrow for all who registered. We will answer as many questions as we can at the end of the webinar. You can submit your questions in the questions section on the side panel of your screen throughout the webinar, and I will choose a few for Mark to answer when he's done. Once again, we will send out the webinar and a link to the presentation tomorrow once we have everything done. If you're not familiar with precision analytical and the Dutch test, Dutch stands for dried urine testing for comprehensive hormones. Our validated 24-hour 4-spot dried urine test provides a complete evaluation of sex, adrenal, and adrenal hormones, including metabolites for baseline hormone testing and effective hormone replacement therapy and monitoring. We offer simple and convenient at-home collection for patients and an easy drop ship option for providers. And our advanced testing methods help providers answer the most complex clinical questions with the most reliable and trusted results. In addition, our customer service and in-house clinical consulting team are always available to answer your questions. At this time, I'd like to introduce to you Mark Newman, our presenter today. Mark Newman is the founder and president of Precision Analytical, creator of the Dutch test, and is a recognized expert and international speaker in the field of hormone testing. Mark has spent nearly 20 years within specialty laboratories developing and directing 24-hour hormone testing, organic acid testing, and salivary hormone testing, gaining a unique and thorough perspective on blood, urine, and salivary hormone testing. This unique experience led to a vision for a revolutionary way to test hormones. Mark began his own lab, Precision Analytical, and is the creator of the Dutch test. The question of how best to test hormones is what drove the creative process that initiated this lab. Blood, urine, and saliva testing are all have significant limitations. Dutch has a unique testing method which bridges the gap between existing methods to create better tools for healthcare practitioners to address the needs of their patients. Mark is committed to advancing innovations in hormone testing and helping healthcare practitioners find solutions and treatment protocols. Mark has educated thousands of physicians on the different hormone tests available and best practices, especially in HRT and BHRT monitoring. So, without further ado, please join me in welcoming Mark Newman. It's all you, Mark.
Thanks, Tim. Happy to be here today, and thanks for everybody joining us. Tim mentioned that we have a clinical staff that's available to answer questions, and today's webinar is about an area where we get a lot of questions because it's a complex topic, and that is androgen testing. And we're not just going to hone in on the Dutch test, but we're going to look at the pros and cons, which is something we like to do often to try to help you as practitioners understand where are the strengths and the weaknesses of all blood testing, urine testing, and saliva testing, so that we can leverage the right tests at the right time for your patients. And oftentimes, we do these types of seminars because it's great for education, it's good at growing our business, In this particular case, my concern is not that you're all using Dutch testing more. My concern is with this complex topic, is that you're reaching for the right tool at the right time, that you understand the strengths and the limitations. No one's in a better position to highlight the strength of what we do than we are, and so we do that. But likewise, no one's in a position to really help you understand some of the caveats of using a urine-based test when it comes to something complex like the androgens. And so today we really want to go through the details of that so that we understand. So I didn't write out an objective slide. So before I get started, let me just tell you kind of what we're going to do. We're going to go through serum, saliva, urine. Like, what are the pros and cons? Why would we grab one of those tests at a particular time? And then we're going to talk about the validation. I'm going to show you some of the validation data for the urine testing, show you where it's strong when it comes to this story of the androgens, and then also show you some of the unique challenges of measuring androgens, particularly in urine, so that you're well informed on that, because there are some interesting idiosyncrasies to urine testing of androgens. And then we're going to dive in at the end a little bit to hormone replacement therapy monitoring and how some of those metabolites that we measure are helpful for that. Let me get my camera out of the way and we'll get started. So just a reminder here of what we're looking at. 3 different tests, 3 different forms that we find it. So let's just say in a female, the ovaries make some testosterone. Obviously, it's going to be from the testes. In men, that hormone represented there by the little purple H is going to circulate mostly bound to a binding protein, right? SHBG, sometimes albumin. When we draw blood, that's what we're measuring, is total hormone. And when we say total, we mean the hormone that's free, which is not very much, and then the hormone that is bound to the binding protein. That's what we get in blood. Now, the free hormone is able to slide into saliva. So when you measure testosterone in saliva, you're not seeing the protein-bound hormone, you're just seeing the free hormone. Now, if we're talking about urine, that's also true as it relates to cortisol. So when we measure cortisol in urine, we're measuring free cortisol, just like all the hormones that you would measure in saliva. But when you talk about a hormone like testosterone, can it get into urine? No, it really can't, because it's not water soluble enough. So it can't get in until it hitches a ride to the liver and gets a polar little moiety put on it. So now it's not testosterone, it's testosterone glucuronide or testosterone sulfate, right? You're not able to conjugate it like that unless it's bioavailable. So it's a nice reflection of bioavailable hormone, but it is a different type of measurement. So for each of these measurements, they're actually different. They should correlate generally, but it's never going to be apples to apples to apples. So we have to think our way through this when we look at the pros and cons of using those tests, whether it's for baseline testing or for hormone replacement. So with androgens, and again, this is sort of the heart of this talk, is it's complicated relative to other measurements. So in women, elevations in androgens seem more easily tied to clinical outcomes. But androgen deficiency, particularly in women, that's where I think you probably get the most complex picture of what's going on with the androgens. And what we're going to see is that a broad view of the androgens seems prudent, and particularly for females. So looking at DHEA, looking at testosterone, but also the metabolites. And we're going to talk a little bit about the advantages of using both serum and urine in combination to get a complete picture when it's necessary. So first, let's talk about serum testosterone. So it is, I would say, the most reliable way to monitor testosterone as a single test. Like if I want to look at testosterone and that's all I want to look at, serum is the most reliable way to do that. You're usually going to test it in the morning because there's an up and down pattern. It's going to be highest in the morning. You do lose that as you age, but usually if you're going to standardize it, that's the best way to do that, is to do an early morning blood draw to look at testosterone. You're going to want to include things like SHBG, albumin so that you can calculate a free testosterone. Now, there's a whole conversation to be had about whether measuring free testosterone is better or calculating free testosterone. My experience in that is limited, but my understanding of free testosterone, not as a calculated value, but as an actual measurement, they're pretty sophisticated tests. They're difficult to do well. So for me personally, I would rather know what SHBG and albumin are doing and then allow free testosterone to be calculated. As your SHBG goes up, that's really relevant because the amount of free testosterone is going to go down. So you're going to have other tests as well, sometimes sex specific, whether you want to look at estradiol or LH or FSH or some of these other tests. But when we're just talking about measuring testosterone, the one thing that's really important, particularly in the female levels, is we really need to make sure we have an accurate test. And it makes a huge difference. So let me show you the data where I would draw this from as an analytical guy, and then I'll show you the clinical data. So you can see here, it's testosterone. What are we looking at here? What we're looking at here is on the x-axis is what we'd call our gold standard method. So that's your LCMS. And then if you want a cheaper test, you can do just your standard assay, which pretty much any lab can do. And when you look up in that male range of 200-ish to 1,000-ish, it doesn't really matter which test you use. So save a few bucks and do it the cheaper way, that's fine. But when you zoom in on the female range, the cheaper assay, they're basically moving away from LCMS, I think is not advised. You see the same thing with estradiol. You see all this data that looks nice, but when you zoom in on the postmenopausal range, where you're going to find postmenopausal women, men, children, the cheaper test basically falls apart. But when you're looking at serum free testosterone, it is meaningful, particularly in looking for elevation. So this particular study, we don't need to read the specifics of this, but they found that free testosterone really did a nice job of differentiating PCOS patients from patients that don't have PCOS. So as you have higher androgen production, higher testosterone, when you're looking at both total testosterone, but especially free testosterone, if it's measured well, you're getting a nice differentiation between PCOS, and I'm using PCOS studies a lot here because PCOS matters, but in a way almost representatively of those that have elevated androgens in the female population. You can have high androgens and not be PCOS, but when you find people diagnosed with PCOS, it helps us understand whether a lab test does a nice job of differentiating between those with high androgens and those that don't. Now, here's a study that's looking for low androgen issues, and they concluded no single androgen level is predictive of low female sexual function. So they're looking at stuff related to low androgens, and they're looking at androgens, and they're basically saying, well, we don't really see anything here. What's weak about this test is, one, they don't include metabolites, which we're going to show here are actually potentially as important or even more so in some cases than testosterone itself. But the bigger issue with this particular test for testosterone is they're using one of those cheap assays, an immunoassay. And here's a paper that I've never really seen someone get quite this sarcastic in a peer-reviewed article, but they actually named this, is this better than a guess? And then they actually wrote, guessing would be more accurate and additionally could provide cheaper tests because you don't have to test. So they're being a little bit tongue-in-cheek there, but what they did is they looked at the immunoassays for testosterone. So that's, again, just your standard cheap hospital test or lab test for testosterone that's not LCMS. And when they really broke it down, they said, we literally aren't much better than just guessing, which obviously is not where you want to be as a provider. Here's another paper that just starts to give the message that this is pretty complex, right? Serum testosterone levels do not account for the testosterone synthesized in peripheral target tissues and the individual variability and the sensitivity of the androgen receptor. Furthermore, the clinical effects of androgens are tissue specific and not solely related to serum levels. They are affected by metabolism, by aromatase, which turns it into estrogen, by 5-alpha reductase, which turns it into DHT, and influenced by other factors that can cause upregulation or downregulation. Moving over to the right, low androgen concentrations in women do not reliably predict clinical findings, and serum testosterone levels are not independent predictors of sexual function in women. So part of the difficulty, if you think about testosterone, is you make estradiol, right? And we measure estradiol, and it matters, and its metabolites matter. But none of its metabolites are better at doing what estrogen does than estradiol itself, right? So the metabolites help fill in the picture. Maybe they teach us something about breast cancer risk, and they give us a more complete picture. But estradiol is the one that matters the most, right? When you go to progesterone, progesterone matters the most, although the metabolites are interesting. Allopregnanolone is interesting as it relates to oral progesterone and sedating effects, but progesterone is the main thing, right? With testosterone, you know, DHT is 3 times as potent as testosterone. So the hormone that we talk about and that seems to matter the most is actually significantly less potent than what it gets turned into. And that's why testosterone gets a little bit complex when we go to measure it. And here is an interesting study where they said the glucuronidated androgen metabolites are stronger predictors of bone mineral density than testosterone or DHT themselves. And so we start to unpack that this is pretty complex. Here again, in the yellow there, intracrine androgen synthesis is often not reflected by circulating androgens, but rather by androgen metabolites and conjugates. And we're happy to share these papers if you'd like to see. If this one shows sort of pictorially what's going on. So this is why it gets complex. Is testosterone is circulating, and like DHT is also circulating out here in circulation. And then, but what happens is testosterone goes in the cell. In the cell, it gets turned into DHT, and that's the DHT that really matters, right? And it does its thing. It hits the receptor stronger than testosterone. But within that cell, it gets turned into a DHT metabolite. Here they're calling that the 3-alpha diol. That's actually one of the things that we measure on the Dutch test. So you have 3 different things in the androgen sort of pathway here, but what's going on is within the cell. We don't necessarily get a window into that cell, but you can see what they're saying here. The title of the paper is that implies that what matters the most is happening in the tissue, right? And then this paper, which is just from 2019, says it's important to consider both androgen precursors and metabolites when assessing androgen action. While androgen precursors and active androgens can be measured in serum, it's often more convenient to measure their metabolites in urine. So serum testosterone is an important measurement. It's most reliable in serum when we're just talking about testosterone, but the picture is more complex than that because the things downstream from testosterone are really, really important too. I'm not going to talk about serum measurements of androstenediol glucuronide, but that's essentially what you end up with is testosterone turns into DHT, which turns into androstenediol, which is then conjugated. And the paper that I just showed you implies that that measurement in serum is actually a better way to test DHT in serum than to test DHT itself. So it's complicated. Does serum testosterone matter? Yes, particularly for elevated women, PCOS, those types of things. It does a pretty good job of differentiating. But when you get down to asking questions about deficiency, it gets a little bit murky. Now, what about saliva? Saliva has the potential to effectively monitor baseline testosterone, but the levels are very low. And typical methods, I think, are really not up for the challenge for what's usually used commercially. Now, LCMS is best, but it's difficult to do as a laboratory. Most labs don't use that. But look, here's the potential. This is salivary testosterone, and this is a blood sample measuring free testosterone. And that's gorgeous, right? That shows some really nice potential. That's from an RIA, which is kind of an older type of technology, but it involves a lot of work of prepping the sample a particular way to make sure that the analysis is good. That is not a method that's available commercially. I would expect that that data would match up really well with LCMS data, but not necessarily with commercially available, which tends to be EIAs, LIAs, sometimes you want to say ELISA. The typical tests that are available don't have great data associated with them. So here's some of the published data for salivary tests that are actually commercially available. So in this one, it's showing estradiol and testosterone, and looking at blood levels. You can see the estradiol levels here, this is actually the only serum correlation data of estradiol that I've seen for salivary estradiol that's shown with a commercially available assay. And it's just not a very good correlation, right? We're looking for a 1-for-1 correlation with our R value at least at 0.7 or 0.8. And with testosterone, it's a little bit better there, but it's not great. At those low levels, the assays are not great. Now, here's a comparison where they looked at, this is just saliva samples tested one way, gold standard mass spec, and then 3 different assays that tend to be used more in commercial testing. And so you're hoping to see things right along that orange line with the value there that's a whole lot closer to 1. So there's 3 different assays. What they're basically saying is it's difficult, right? What we showed in blood is that when you use this type of technology, when you get down into the female range for blood, it kind of falls apart. And in saliva, even the male range is down that low because there's less hormone in saliva. And so you just don't get great data unless you're using pretty sophisticated methods, and that doesn't tend to be what people are using. So again, that on the left is a saliva sample measured one way and measured another way. On the right, with a more sophisticated method, that's saliva versus blood. So that's much more difficult to get to correlate because it's a different sample, right? And yet it's a lot stronger. Why? Because the methods are more, maybe sophisticated is not the right word. Accurate would be probably the better word. So saliva shows potential, but what's available is probably not the best option. This is not the place to get into this whole debate, but you do find people who believe that the unique message you get in saliva for creams and gels for testosterone are more clinically accurate. If you actually look at the clinical data that shows what happens with creams and gels clinically, and then you look at urine and serum, it aligns much more strongly with what happens clinically. So I would definitely not use saliva for HRT monitoring. And so for us, we can develop salivary testosterone if it has a unique message. We do it by LCMS. We could do that if it was helpful, but we really feel like with the current state of things, that saliva is just best used for cortisol. So that has left people historically with this sort of combination of, measuring sex hormones in serum, hopefully using LCMS here and here, and then going to saliva to get the cortisol picture because cortisol is not very good in saliva. And that's where Dutch came in and said, look, if we can measure these hormones and we can measure the metabolites and some of these other things, like that's a nice way to go. It also gives you the cortisol pattern, and that's our Dutch complete. And then if you say, well, I really value, which I do, the cortisol awakening response, not just the up and down pattern of cortisol, then you're going to go to the Dutch plus. Just for a second before I get into the particulars of urine, I'm just going to brag a little bit on our published data over the last couple of years. So we published our cortisol data showing that if you use dried urine collections and you look at this up and down pattern of free cortisol in urine and saliva, you get nice correlation between the two. That was a really important data for us to publish for both of our assays. Serum correlation, 24-hour urine correlation for estrogen and progesterone. So that paper was published in 2019. You can look at that if you want. And I will just say this was pretty exciting, so I'm going to share this with you, even though it has nothing to do with androgens. The North American Menopause Society accepted 3 of our abstracts looking at our clinical data when on therapy. So looking at, here's your postmenopausal range, premenopausal range, and then this is our actual data from all of the testing we've done over the years, looking at estradiol patches and looking at the different doses from lowest all the way up and seeing that data scales nicely. We showed the same thing with gels. So that was a separate publication for North American Menopause Society. And then we also looked at creams. So this is estradiol creams, and we did a little 3-way comparison, and that was also accepted for publication for North American Menopause Society that shows that the lower dose is getting you outside the postmenopausal range and the highest dose into the premenopausal range. And there's some interesting stories to be told there, but pretty excited to be sharing that at the North American Menopause Society meeting here in the fall. But lastly, androgen metabolites. So that was published just this year in BMC Chemistry. And so what we looked at there is correlation of Dutch. So that's our 4-spot urine test here, and a true 24-hour urine on the y-axis. That was an important data set for us to publish. So those are some androgens there. We published liquid versus dried. We also published some of our organic acids, which relates to this story, but we're not going to get into those today. But you can see that all in that publication. So the Dutch test is validated for the androgens, equivalent to 24-hour urine, precise, accurate analytically. So what does that mean? That puts us in a position where we are then simply dependent on urine. Like, so the pros and cons of measuring in urine is something that we need to understand really well to know the pros and cons of using the Dutch test as it relates to DHEA and testosterone. Like, how does it work in urine clinically? So here's a publication where they look at, this is a good question to start with. If I look at a bunch of women with PCOS and I look at a bunch of women without, do I get nice differentiation? Because that ultimately is what lab testing is for. Do you have meaningful differentiation? And what you can see here that I want to point out is the strongest performer keeps coming back to this DHT metabolite called androstenediol. So in blood, again, testosterone gets turned into DHT in the cell. In the cell, it gets turned into this guy, and then that guy gets conjugated. So now you have a 17-glucuronide and a 3-glucuronide. And one of those papers we showed you said, hey, those correlate really well to bone mineral density in men, more so than testosterone itself. Well, both of those conjugates end up in urine, and then in urine, it gets measured as a total. And when they measured those in women without PCOS, you can see the range that they got there. Look how well separated that is from the PCOS group. So all of these metabolites are much higher in the PCOS group, all of these androgens, but androstenediol especially completely separates the high androgen group from the control group. That's pretty nice clinical utility for a urine test. So what are we trying to do with urine? We're trying to tell three big stories here. One is, how much of these adrenal androgens are we making? So that's DHEA and androstenedione. And what we're doing with those three is just adding up the three metabolites of DHEA that are the biggest. So if you look at these three, you can see that those are not only the biggest numbers, right? So that it just basically says, if I put a bucket out and catch all the androgens that are made, at the end of the day, these are the three forms you find them in most, right? Is DHEA, and androsterone, and etiocholanolone. And look what happens when you look at the median in the controls relative to the PCOS group. You get a lot more in that PCOS group, right? So this is, again, showing nice clinical differentiation between people in a state of high androgens and people that would be considered normal. So the Dutch story is going to include these. So this is a new report format that we're still working on. We were hoping to release this a little bit ago. COVID kind of got us sidelined, but this is not that dissimilar from what you're used to if you're looking at Dutch testing, which is that our normal range is like here. Within this now we have embedded age-dependent ranges. So the younger folks are going to be here. The women over 60, this is actually, I'm not sure if this is male or female, but you can see the age-dependent ranges right in there. So what's this person's story? Holy cow, they're making a lot of DHEA, right? And you can see then the three things that make that up: DHEA-S, etiocholanolone, and androsterone. Those are the three primary metabolites of both DHEA and androstenedione, which reflect overall production of those. And those bottom two can only be measured in urine. Now, one of the other things we can see after we look at DHEA and androstenedione production is relative metabolism. So let's just make a theoretical person that has the same exact total here, right? Same DHEA-S, but they're pushing more down that 5-alpha pathway, right? So in the periphery, in the active tissue, you get a lot of 5-alpha metabolism. 5-beta metabolism is the other way. It is important to note this is not a tug of war going on in the same cell typically. The liver's mostly responsible for 5-beta, and within target tissue and in the periphery, you get a lot of this 5-alpha, and 5-alpha metabolism is pretty important. And you can see here that this theoretical patient on the right is the story I would tell here, is that they're making the same amount of these adrenal androgens, but they've got this highly androgenic metabolism going on, because when androgens go 5-alpha, they get stronger. When testosterone goes 5-alpha, it turns into DHT, and it's 3 times as potent. All androgens get more androgenic as they go down that alpha pathway. So it's an important marker to look at 5-alpha. And we have actually, if you want to get like into the nitty gritty, we have 4 places you can see that. What I just showed you is androsterone and etiocalanolone. That's mostly what you're going to see in the literature. But you've got 5-alpha androstenediol, 5-beta androstenediol. Those are testosterone metabolites. You have cortisol metabolites, so THF is tetrahydrocortisol, and there's an alpha and beta pair. Pregnanediol, those are your progesterone metabolites. Again, a 5-alpha, 5-beta pair. So you can look at those if you're looking for confirmation of a story of somebody who's pushing in a particular direction. You can look at those. Here's some of our data that just shows that it's not exactly if you're pushing 5-alpha or 5-beta for one of these pairs, like the androstenedione pairs. If you look at a different pair, they correlate pretty strongly, but they're not 1-for-1, right? This is a paper looking at PCOS and not the amount of androgens, but the metabolism. Do you see 5-alpha metabolism? And this is an overview paper that said when we look at androsterone and etiocalanolone, you can see that there's an overall preference for that ratio going up, meaning a 5-alpha preference. And if you ask that same question, but instead of using the androgens, you use cortisol, we know that there's a preference there too. Well, what's the heart of that story is usually insulin, right? Insulin turns up 5-alpha reductase. So when you start looking at people with diabetes, they make more 5-alpha THF, they make more androsterone, they make more DHT. And that's how we assess this, is to look at the ratio of those. So the 3 big stories are the androgen production of adrenals, DHEA and androstenedione, 5-alpha metabolism, am I pushing more androgenic or not, and then testosterone production. Men, of course, it's almost all coming from the gonads. In premenopausal women, it's about 1/4 from the adrenals, 1/4 from ovarian, and then about half that gets converted peripherally within tissue, that sort of thing. So if we look at a female case study, here we can actually see all of the androgens that we're looking at here. So we can see testosterone is, the range is 2.3 to 14 there, and the testosterone for this particular woman is normal. DHEA production is a little low if she's in that younger age range or the age group, but reasonable DHEA. And then what do we get to do? Then we get to go look at metabolism patterns. And you can see in this particular case, I chose this one, of course, because it's kind of a slam dunk to show you what an obvious case looks like. Testosterone is getting pushed 5-alpha big time, right? Androstenediol, which is that really important marker that tells me how much DHT is being made in the cell, more so than DHT itself. So this is a really important marker. The the testosterone that's going down the non-androgenic pathway, there's not very much of it there, right? And here, same thing, 5-alpha, it's 5-alpha heavy, 5-beta light, right? So if we want to look further, as I mentioned, you can even look at progesterone metabolites, 5-alpha heavy, and THF. We don't plot THF with a dial like this. I just made one so you could see what that would look like. The range ends at 370, and boom, she's at 400. So lots of alpha, whereas beta THF is on the lower side. So the point is, in some cases, it's very obvious that you have this huge 5-alpha preference. What's that going to mean? That means in the tissue, you're making lots of androgens. It means you probably have an insulin issue. And so you want to go and explore that in terms of how you're going to treat this patient. Now, if I look at a male patient, we can kind of look at that just briefly here. So here's testosterone for this guy. And here's the total DHEA production. So if this is a young guy, right, he's actually, within the larger range, but he's normal for a 60-year-old, not normal for a young, healthy guy. So if he's younger, that's a little bit on the lower side. I think this is actually a report from an older gentleman. Now, the 5-alpha picture that you can see here, when you look down here, it's pretty similar, right? You've got kind of middle of the road, looks like a slight maybe alpha preference. And then when you look at androstenedione, you get more of an obvious alpha preference for this particular guy. Now, keep in mind, this is not always a clear-cut thing, because you've got 5-alpha reductase type 1 and type 2. You have different metabolism going on in different tissue that have different sensitivities. So, you know, we can't always know precisely what's going on. I always start with that story here, because again, that's more, it's more in the literature. We know that those correlations bear out when they look at them in the literature. But then we've got these other 3 pairs of 5-alpha, 5-beta metabolites that can help to confirm maybe how strong of a leaning a patient might have. Here's a second guy who's kind of middle of the road for DHEA. But if I told you, which it is, that this is a younger guy, you know, he's a little bit on the low side for DHEA. The 5-alpha, 5-beta, if you look there, pretty similar, right? There's no real leaning in that sense. And down here, pretty similar, right? What you see here for this guy is the testosterone super high. This is actually getting a little bit ahead of myself, but this is a gentleman who's actually taking testosterone. So he's actually taking, this was either an injection or a pellet. I think it was an injection. So, and that leads us into something that we'll get to in just a minute, which is this other interesting androgen that we've been testing, which is epi-testosterone. So epi-testosterone is kind of the cousin of testosterone. It's made in about the same concentrations, but it's not androgenic. So it's just there as sort of a flag to say, hey, here's a second look at what your gonads in a guy might be making, and why in this case is it so low? Because he's taking an injection, right? The injection tells the brain, we're done here, and stops your LH production. So we can see here, he's got a fairly high testosterone, almost all of which is coming from exogenous testosterone. And then we can look downstream to see how he might be metabolizing that testosterone. So the advantages of urine: 24-hour production is helpful, given that it's variable if you measure it at any moment in time, but there's also a diurnal pattern. It includes adrenal and gonadal androgens. It's LCMS work, which is nice in terms of accuracy. There's not a ton of data in the literature on testosterone replacement, but from all the data I've looked at, injections, pellets, creams, and gels, it seems to be helpful. We'll get to that in a minute. But first, I want to talk about this. Is conceptually, if we limit the story, urine has a really nice story to tell. We can add that into the serum story, or we can use it independently, and you get a lot of interesting things to try to overlay the clinical picture with, and to see what's going on with a patient. So what's the problem? It's an imperfect test when it comes to measuring androgens in urine, and I want to make sure that we talk about those. There are significant caveats to measuring androgens in urine. DHEA production is best tested. This is what we already talked about. Add the 3 big ones up for DHEA. Now, when we're talking about DHEA in urine, you don't really need to remember this, but just to be clear about what we're actually measuring, we're taking DHEA sulfate, DHEA glucuronide. It would be the same for testosterone. Testosterone sulfate, testosterone glucuronide. But when it comes to DHEA, it's almost all sulfate. So we actually call it DHEA-S, even though it's the total of those 2. There's just not very much of the glucuronide. But it seems to tell a little bit of a different story than serum DHEA-S. And the reason that I say that is because there's not much of a diurnal pattern with DHEA-S in serum, but there is in urine. And so it seems to be telling a little bit of a different story. Androsterone and etiocalanol are the most abundant. And so again, what's the most helpful there for DHEA and androstenedione production is to add those 3 up and to measure those, which is a little different than what we're doing in blood. But the most significant caveat to measuring androgens is testosterone. Testosterone can be artificially low in urine due to phase 2 conjugation issues. If you've run a lot of Dutch tests, You've run into this. You've probably jumped on the phone with somebody to talk about this. The UGT2B17 enzyme, that's what conjugates testosterone. Turns it from testosterone to the glucuronide. It has a variant form that just basically doesn't work. So this is probably, to me, the biggest caveat to using urine hormone testing, is trying to understand and wrestle around this issue. So when we started, we showed you this conjugated form, right? It presupposes, urine testing presupposes normal phase 2 metabolism. Usually that's almost always true, but the glucuronidation of testosterone doesn't always happen normally. So the liver is putting on this little sugar moiety, right, so that it can go into urine. So if that doesn't happen because you have a variant form of that enzyme, then what's in your urine is going to be artificially low. So the glucuronidation, that's adding this to an OH group, doesn't always happen normally. And the easiest place you can see that is when you look at urine testosterone in people who happen to be white and people who happen to be Asian, and you can see that the level, most of the graph on the left is represented here, right? So you say, well, they just have lower testosterone? No, when you look at free testosterone in blood, they're pretty similar, right? But then in urine, they're way lower. Why? Because it can't go that route, right? It has to find its way out through other metabolites because of the fact that phase 2 conjugation isn't happening, right? So it's more than 60% of people with Asian descent that have this variant form of the 2B17 UGT enzyme, right? It's less than 10% of other ethnicities. I think in Caucasians, it's 1 or 2%, something like that. It's caused by a gene deletion, okay? There really aren't a lot of physiological consequences for this. So this is not like, hey, something's wrong here. Although I do want to say that there are papers that show that maybe it makes testosterone hang around a little bit longer. And in this particular study, they found that women who had this gene deletion actually had better bone mineral density. Testosterone helps with bone mineral density. You make it hang around longer. So there are some maybe clinical nuances, but mostly it's just a pain in the rear when you're trying to use urine testing when this comes up. Because as you look at the flow chart, right, so you're making from androstenedione in the gonads of men, you're making equal amounts about of testosterone and epi-testosterone. But then this can't find its way into urine, nor can DHT, nor can 5-beta androstenediol. So what does it look like? Low, low, low. Those three are all put into urine by the same enzyme. Epi-testosterone, different enzyme. 5-alpha, that one we really liked, and thankfully this is true of it, is not conjugated by the same enzyme. So testosterone is falsely low. DHT and 5-beta androstenediol are also falsely low, and epi-testosterone and 5-alpha are what they should be. That's the pattern that we look for to say, hey, there's some uncertainty here as to whether this testosterone value is actually speaking correctly for this particular patient. And that's one of the caveats, of the biggest, I think, of using urine testing, because those three are conjugated by the same enzyme. So pros and cons, it's a better average over time than serum and saliva. That's nice. You get accurate numbers analytically because you're using all mass spec, and it reflects bioavailable hormone, but only if phase 2 is appropriate, which again is almost always true across the urine board, but it assumes that's true, and here that isn't always the case. So what? So what do we do about that? And this gets important. So patients not on TRT, urine is a useful secondary test for testosterone. Serum is going to be primary when you're looking at testosterone itself. It's not going to be reliable for patients of Asian descent. So I would be really cautious about leaning on any of those three markers in someone who has, Southeast Asian descent, Chinese. That area of the globe tends to have a lot of that variant enzyme. When epi-testosterone is higher than testosterone, be suspicious, especially if DHT and beta androstenediol are also low. If you have that complete pattern, our reports, because we've really dug into this, right? We put a comment on the report that says, hey, be aware of this pattern. We probably need to confirm with serum before we draw any conclusions. So confirm with serum before TRT for sure. And 5-alpha androstenediol may emerge as having more clinical utility as we continue to dig into androgens. So here's a gentleman just looking at a couple case studies to say, okay, what do we do with all of this information that we have? Here's a guy who has relatively low DHEA. This is another young guy. So it's relatively low for a young guy for all of these metabolites. And testosterone is pretty healthy, but there's a reason for that. This particular guy is on Clomid, right? So he's taking Clomid, which makes your brain make LH, which then stimulates your testes to make testosterone, which is going to help you make testosterone. Epi-testosterone is in the same neck of the woods as what we typically see. It's a little bit lower here. And then that's getting pushed pretty heavily down that 5-alpha pathway. We want to consider all of that when we're looking at therapy, when we're looking at baseline testing. Okay. Here's a female patient. So what are we going to do with this patient? She's got relatively high testosterone, right? And then we're going to look further to see how much she's pushing it. There's a real heavy push down the beta pathway here, where she's way outside the range. You can see that consistent here, where the androstenedione metabolites are also pushing towards etiocalanolone. So when you're a little bit out of range and you're not a 5-alpha metabolizer, a little bit less on the 5-alpha, that's where we really want to overlay the clinical symptoms here too, to see, how is the patient feeling. So imperfect with significant caveats for urine androgens, but the most common place, and this is where I'm kind of weaving this whole story to, for urine to steer you wrong potentially is with low testosterone levels that may not reflect the clinical picture, right? That's what we have to watch out for more than anything. We want to check the metabolites, especially 5-alpha. Check overall DHEA, especially if they're postmenopausal. Why? Because once the ovaries stop, right? The ovaries give up and quit making hormones, where does your testosterone come from? It comes from the substrate of DHEA, androstenedione. So looking at that can really help to tell you the story of what their androgens are looking like. Check epi-testosterone, but, and this is where it gets a little bit complicated too, only in premenopausal women. This is actually new data to me, which is really interesting, is it's just a bunch of aggregate data for us. And you can see that androgen levels are dipping over time, right? But epi-testosterone kind of falls off a cliff around menopause, which I think implies, I've not found this in the literature. So I think this is again, where the androgen story, when you're looking at these papers, they're pretty recent, right? Where the story is still being told in terms of what are the absolute best markers to look at. And one of the things I don't think that's been really unpacked yet is that it seems like the epi-testosterone must be coming more heavily from the ovaries, or that would be my interpretation of this data. So when you're young, the epi-testosterone helps to parallel testosterone for women, but when you get into the older women where it's all coming predominantly from the adrenals, then epi-testosterone is going to drop off more so than testosterone, so it's not going to be as helpful. So the other things we can do, of course, are to check our serum testosterone, and of course to look heavily at how the clinical picture overlays with the patterns that we're seeing with the biomarkers that we're measuring. So here's a woman who's 22. The doctor said she had a bunch of exposure to some pesticides or herbicides or something like that they were kind of investigating. You got a lot of estrogens. You can look at a lot of these above, a lot of estrogen. And then when you get to the androgens, you see, again, young woman. So here's her story. So what would we do with this? DHEA and androstenedione, so here, and here, are pretty decent levels, right? So she's making a decent amount of those adrenal androgens. We can see that she's got pretty heavy 5-beta metabolism, right? The 5-alpha metabolite is not down here with it. It's quite a bit lower. And then you notice what with testosterone? It's low. We actually tested her again 3 or 6 months later, it was 1.2. So it's consistently low. She's got plenty of DHEA to feed into that, right? Her ovaries are obviously working to some degree because she's making a lot of estrogen. So then this is where I have some pause to say, okay, like what do I do with that? And the first thing that I'm going to check is the 5-alpha androstenedione, which is also low. that's a big conclusion because it confirms that she may not have a lot of testosterone. In this particular case, it gets a little bit more confusing because she's got a fairly decent amount of epi-testosterone. So this is the type of case where we have to say that there remains some uncertainty. What does her clinical picture look like? And then if we really want to focus in on the androgens in a case like this, we may need to also look at serum androgen markers to give a more complete picture of what's going on. It appears, again, with the low testosterone and the low 5-alpha androstenediol, that she does actually have low testosterone. If the 5-alpha androstenediol was significantly higher, my level of uncertainty would go up even more, because that is really a nice marker for overall like androgenic exposure, right? That's a really nice marker to be looking at, which is why in our new format, which we'll be getting out to you next year, we're actually putting those 5-alpha, 5-beta markers on the flow chart for women, because I think it's going to be helpful as you look at this full picture. But this is the type of case where we get on the phone with people and we have to really talk through it, because there is some uncertainty left. Once you understand it completely, there still is some uncertainty to that, right? And that, again, is for all the wonders and amazing things that urine testing has to offer, this is the one area where there is a lack of idealness to what we have here, because of some of the things that we've just talked about. So we want to be careful when we're looking at cases like that to be really thorough in both what we're monitoring and what we're considering before we think about any particular type of treatment. Now, I'm running a little bit longer than I thought, so let me just scoot through some of the TRT applications. Of this is honestly, to this point, is trying to get you to a position of understanding the pros and cons of this, some of the nuances of this. And so we could stop right there and take some questions, but I want to just knock through this. This is kind of the fun part for me, where you can see some of these unique urine markers are actually pretty interesting. Before I do that, though, I want to make sure and remind you of something that we avoid a particular mistake, and that is, as we understand what happens physiologically, LH comes from the brain, it's going to get into the testes, right? And that little star protein grabs cholesterol, goes into the mitochondria. Here's where your pregnenolone comes from for testosterone, right there. And then pregnenolone goes where? Outside into the endoplasmic reticulum. That's where your DHEA comes from, right there. And right there, it gets turned into testosterone. So that's within the cell. And then it can, of course, go out and do what it does in general circulation. The reason I tell you that is just to remind you, you cannot rival testicular production of testosterone by giving DHEA to men. Right here in the cell, DHEA gets turned into testosterone. So if you flood DHEA into their system with supplementation, you're not going to get it in the middle of that chain of making testosterone, which means you're more likely to make a truckload of estrogen, or at least as likely. So yes, you're going to give a little testosterone, but in women, it'll trickle down to testosterone. You can't trickle down to levels that are going to rival testicular production. So just don't think that's going to happen. That could be a mistake. So for patients on TRT, urine is a useful secondary test. I love it because we get so much information, but I think when you really want to hang your hat on testosterone, serum is primary. Again, not reliable if you have a person of Asian descent. Use Epi-T, this is an interesting one, as a surrogate for approximate testicular production. 5-androstenediol is also going to be helpful, okay? So Epi-T is also made by the testes in men. It's not androgenic, so it's not really doing anything important that we know about, but it acts as an interesting marker, and it's just different at that one little position, but that makes it not androgenic. It's made in similar concentrations to testosterone, and again, approximate testicular androgen production. So let me show you this in practice. So if a typical aging man looks like this, maybe around 40 for both, with TRT, Epi will go down to the extent that LH and gonadal androgen production is suppressed. Let me show you this in some examples, and then it'll make a lot of sense. So a typical aging male, maybe you treat that person, maybe you don't. That's not for me to say. But the person who's below the entire range, maybe you're going to treat. So what happens? So this is not an individual person. This is our aggregate data. This is me going into our data and say, what do all the people on 25 milligrams look like? They look like this. How about 100? How about 200? So what happens here? With each dose increase, testosterone's going up, right? That's what we'd expect. Epi-testosterone probably hasn't been touched with 25 milligrams. That's probably a baseline level. As 100, it starts to get suppressed, and somewhere between 100 and 200, we've sort of broken its back. If you're less than 5, really even less than 10 in a guy, that tells you that your man is not making any testosterone himself. Here's 3 days post-injection. Tons of testosterone and full suppression. After 5 days, less testosterone, full suppression. After 10 days, this is where you're ready for your next injection, right? Is probably sometime before this. But all along, full suppression of endogenous testosterone. How about a pellet? Now, keep in mind, our aggregate data is probably a lot of people that use really high doses of pellets, so I'm not endorsing any particular thing here. I just want to show you that early on after pellets, we got a lot of testosterone, full suppression, and then it comes down, full suppression, and somewhere in there, you're gonna put in a new pellet, right? So the point is, epi-testosterone gives you an idea of how you're suppressing endogenous production. Okay, so it's a useful tool, helps identify those UGT variants, because again, it should be at normal levels when the testosterone is artificially low. It approximates gonadal androgen production for the UGT people and for TRT. And just to remind you, we're dealing with lots of complex stuff here, right? You got to think about reproductive hormones, you got to think about adrenal hormones, you got to think about their immune system. So you've got guys who've got stress that are causing low T symptoms, and then you've got testosterone and estradiol and all of this. You know, these situations really can be complex, and that's why we think comprehensive testing is really helpful to pick at those things and figure out, you know, what's going on with a guy, which is, or a woman, as it relates to not just their androgens, but their overall hormone production, right? If you're looking at guys and you're looking at prostate health, you're going to want to know about androgens. You're going to want to know about androgen metabolism, because DHT matters in that story. Estrogen metabolites also matter in that story. And when estrogen metabolites play a bad story when it comes to prostate, the smoking gun of that is thought to be the 4-hydroxyestrogens. Well, how do you get rid of 4-hydroxyestrogens? One of the way is with glutathione, right? So we've also got markers in there that are going to help you put the whole story together in terms of, you know, what's going on with this patient from production and metabolism. You know, certainly you're going to want to look at cortisol and what's going on there in those patients. So looking at comprehensive testing, we think, is really, really helpful. But again, the point of this talk was to understand some of the nuances of the androgens to make sure that we're not over leveraging that information, and that we're understanding some of the situations where we need to take a pause and maybe even do some additional testing to really give us enough detail that we have confidence before we're making, you know, interventions for a particular patient. So that is all the information that I have. I know that was a lot. Thank you for hanging with us. Really happy to answer questions now and after the fact. Again, I realize this is a complex topic. We want to be having, you know, ongoing dialogues with all of you about these types of things where there is complexity, and just to continue to pursue truth wherever that takes us, so that you can understand the pros and cons of all of your testing options that you have. I do think for most providers, the Dutch test is a great tool to have in a lot of situations. And if you haven't tried it and you want to just sort of see how that works in your practice, I would encourage you to get some of our half-price kits that we have for our new providers. For this particular lecture, if you're an existing provider, we'll also offer you 2 of the Dutch Plus kits at half off. And we thank you for working with us, and please do take advantage, especially with these complex topics, of our great team of clinical consultants. They can help talk you through the patterns that you see, what they mean as you get into making decisions about potential intervention for your patients. So with that, Tim, I don't know if you've collected some questions that we can answer, but I will open it up for that now.
Yeah, thank you so much, Mark. I do have some questions for you that came through. One of the first questions was, A4M teaches this, that saliva is the best way to measure testosterone. What would be your comments on that?
So when people say it's the best for measuring testosterone, what they typically mean is that saliva has a unique message when you take the most common form of TRT, which is creams and gels. So when you take, I should have thrown a slide in here. I should have known this question would come up. I was trying to stay away from getting into that because that's like my favorite soapbox. There have been educators that have taught that the elevated values you see, so remember, saliva and blood and urine, they agree generally, you know, in young guys, in old guys, whatever, they agree generally. When you take an injection, they agree. But there's this paradox that when you put on a cream or a gel, the saliva goes up way more than anything else, okay? So then you have to ask yourself, well, which one's right? And the data is not ambiguous on this, okay? The saliva value is outside a young, healthy range with 5 or 10 milligrams. So then saliva testers, the people that promote that, would say 5 or 10 milligrams is a lot of testosterone for a guy, a lot for a guy. So I'll give you a quick test to show you that that's not right. I can show you 8 studies, the 8 studies I found where they've given 5, 10, 15, and 20 milligrams of transdermal testosterone, the same exact products, to women. So what happens if you take too much testosterone for a guy or enough testosterone for a guy and you give it to a woman? They have terrible outcomes, right? They're going to get hair and acne and all of these things. None of those studies reported negative outcomes for the women, right? Because the unique elevation that you see in saliva following transdermal hormone is a concentration of lipophilic hormones that does not have anything to do with any tissue. There is not a single study. I've sat down for more than an hour with Pam Smith, with Dr. Zava, and said, what studies can you show? Because they're the two, and their colleagues and their friends. But I think on this topic, I don't think they disagree with me. I think they disagree with the scientific literature. The scientific literature is clear. When you get clinical outcomes is when the serum and the urine move. So you need 25, 50, 75 milligrams of testosterone to get bone mineral density, to get changes to sexual function, to get changes to muscle mass, to get LH suppression. All of the things that have been studied, all of them dance with the serum. And erythrocytosis is probably the best example. When you give an injection, you get a lot of erythrocytosis increasing. If you give a big injection, even more. So then you say, okay, well, what happens when I give a 50 milligram transdermal gel? Well, saliva says that that's 10 times too much testosterone. If you give 10 times too much testosterone, erythrocytosis will go crazy and you are being unsafe. But it doesn't. As the serum implies, as the urine implies, the erythrocytosis increase is 20% of a typical injection, which tells you the clinical change parallels serum. When you look at the clinical data, it is not ambiguous. The jury is not out on this. It is very clear, but this is an old medical myth that some people have really dug their heels in on. And if you think about it critically, you look at the data, it does not agree with that. It says that when blood and urine move, you get clinical change, and the saliva parallels serum when you're not taking hormones and is completely useless and will not lead to clinical success when you're taking hormone by way of cream or gel. So maybe I should have put some of that in my lecture, because I would add some pictures that would help that make sense. And we've got some blogs and things that address that more specifically. So next question.
Yeah, and one of your prior, one of the prior speakers at Dutch, Androgens, mentioned that topical testosterone treatment should not be measured with serum testosterone levels. Do you agree with that?
No, I don't. I mean, it's a common belief in our industry. Again, when you look at, well, okay, first thing, when you use a testosterone cream, there are 0 clinical studies on creams, so we can't lean on those at all. But with the gels, what we know with the gels is we know that Androgel and all of those, that every study that's ever been done says that as the serum moves, the clinical picture moves. And we know that saliva tests go up, again, in an exaggerated form. And it is a widely held belief that those numbers should be used for therapy. And I have put it to people that are proponents of that to show studies, and honestly, all they ever give are anecdotes. You know, I know a guy who took tests, but there are studies that have studied erythrocytosis, LH suppression, muscle mass increase, all of those things. The bone mineral density is an interesting one. Bone mineral density at 25 milligrams, it barely worked. 50 milligrams, it worked a little bit more. What happened at 12.5 milligrams? It failed. It didn't work, even though saliva values are saying, whoa, that's too much hormone. It failed, because if you're not getting the systemic increase, when you get systemic increase, you're going to see it in blood and urine. And what goes on in saliva is an exaggerated look from fat-soluble hormones. And I don't think it's clinically relevant. And I've never been shown a single study with testosterone that implies that those values. So if somebody said that on one of ours, you know, they might have a different opinion of that. I don't think that's anyone that's on our staff, but it is a widely held belief. But I think it's slow going to get people to see that from a different angle. But the evidence is pretty clear.
That's great, Mark. Thank you so much. Next question. Is there any evidence for testing androgen receptor levels?
That would be fantastic. To know what's going on at the receptor level of androgens, to know what's going on at the receptor level for estrogens and cortisol. I mean, it's a big black box, right? So, you know, that's why in medicine we do a lot of guessing, right? You get all the information you can, and the best doctors are doing the best guessing, because you never really know what's going on at the receptor level. If you have a receptor that's, and I don't know a lot about like receptor science, but just conceptually, if your receptor was 25% as active as somebody else's, you'd need more hormone. And I don't know how you'd ever figure that out, except to really listen to the symptomatology of what's going on in a patient, and to be very careful about the way that you treat them. But none of the lab tests speak to what's going on at the receptor level. So those, it's a great question. We don't have a window into that.
Thank you, Mark. Another question, would you recommend salivary cortisol over the urine cortisol? Someone has been using the Dutch Complete, but would it be better to change to the Dutch Plus, or when would you recommend what test?
So I think the question is priorities. So what we've shown is that the up and down pattern of cortisol is comparable either way. But if you want to say, I want to lean on the literature, you know, we've published our urine data, but that doesn't go into a lot of clinical outcomes, right? If you go into PubMed and you're looking for free cortisol patterns, you're going to see some 24-hour urine stuff that's okay. You're going to see some blood stuff that's like not very impressive, and then you'll see a bunch of saliva stuff. It is better. Urine is a viable option for the diurnal pattern, and in our Dutch Complete, you get a good look at that and all that other stuff for a little bit cheaper price and an easier collection. For me personally, and particularly if I want to look at adrenal issues, I want saliva primarily because it has the cortisol awakening response. Some people, and even some labs that do diurnal cortisol in urine, try to look at that difference between the first urine and the second urine and sort of say, yeah, it's kind of like a car. It's not. It's important information. It's useful information. But a waking urine sample tells me your cortisol while you're sleeping. That's very interesting. I like that value. It's good to know. But it's not, the car needs a value right when you wake up. And right when you wake up, when you take a saliva sample, it says this is your baseline. And we know if you look at baseline and half an hour later, that's a really great mini stress test, right? The biochemistry that goes on when you wake up parallels a stress event. And so the bounce you get in those first 30 minutes has to be looked at in saliva, and it has unique and independent value when it comes to assessing the HPA axis. So if you want to hone in on cortisol, I would use the Dutch Plus. If you got an extra 75 bucks, I would use the Dutch Plus. If you're looking at general wellness and you don't really suspect an adrenal issue, then the Dutch Complete is a little easier, it's a little cheaper, and it's going to give you a lot of information about cortisol. It's just going to be missing that cortisol awakening response. So most of the time I would lean in that direction, but either one can be useful, and I would consider urine-free cortisol a viable alternative to monitoring the diurnal pattern of free cortisol. That's probably the wording I would use. And so you need to use, in a particular case, whatever matches up best with what you're trying to do.
Mark, thank you so much. I know we're not able to get to all the questions. We're about 10, 11 minutes over our hour here, but we just want to thank everybody for participating today, for interacting with us with this webinar. All the great questions, although we weren't able to get to all of them, we're just very grateful for our customers and the providers we work with and our whole team here at Precision Analytical. Thank you, Mark, for doing a fantastic job. For more questions, you can email us, info@dutchtest.com, or you can call the lab, and our customer service team would love to help you if you need help with anything, any of our tests, or if you want to know how you can sign up or whatever you need, just give us a call. So thanks again, Mark. And that's our time for today, and we'll see you in a month. We'll have another great webinar coming up in the month of September. So,
all right, thanks, Tim. Thanks, everybody.
You bet. Thanks.